Hello. It's wonderful to see everybody here. I'm not quite used to speaking over a din, but having raised a family of 3 kids, I have at least some experience with that. It's wonderful to see so many people here with an interest in this, I think, somewhat neglected topic, the topic of the treatment of post-traumatic stress disorder in people with serious mental illness. The treatment model that I'm going to be describing today and our book on it has had over 20 years of, actually over 25 years of work and research. And while this book focuses on the application of the model for people with serious mental illnesses, such as schizophrenia, bipolar disorder, treatment refractory major depression, and borderline personality disorder, the model itself is applicable to any particular clinical group of people who have post-traumatic stress disorder. And in fact, we have experience and other books on applying the model to people who have post-traumatic distress following disasters, to adolescents, to people receiving treatment in primary care settings, and many other clinical populations as well. So I have the major part or significant part of the presentation organized into a number of different kind of questions that are related to the book. And so the first one is, what is the cognitive restructuring program? And so it is a standardized program for treating post-traumatic stress disorder in people with severe mental illness, as you may have guessed by now. I mentioned the common types of psychiatric disorders that are covered in the book, although the reality of it is that it is a manual for treating post-traumatic stress disorder that is highly adaptable and flexible when using with people who have a lot of significant challenges in addition to their post-traumatic stress disorder symptoms. So, for example, we know cognitive impairment is very common in severe psychiatric disorders, especially schizophrenia, and that can interfere with acquiring particular skills or processing emotional experiences. We know that significant numbers of people have hallucinations and delusions. Now, these are characteristic of schizophrenia. They happen during periods of mania and depression as well. But interestingly, you also get psychotic symptoms in just severe cases of PTSD, where the psychotic symptoms can't be explained by other kind of things. And so the model deals with how to separate, for example, psychotic symptoms from post-traumatic symptoms, and in situations where they actually may be both. And also how to work with people with high sensitivity to stress in psychotherapy, which can precipitate, for example, psychotic symptoms or confusion or extensive anxiety and depression and things like that. So the idea of the program is that it's highly flexible in the face of people with significant cognitive challenges that often dominate their lives. The treatment program is supported by controlled research done both in the US and abroad. It's effective in clients with psychotic symptoms, as I had commented, and is associated with reductions in severity of psychotic symptoms. And it's based on the principles of cognitive behavior therapy, but it does not involve prolonged exposure. In fact, there's no formal exposure component of the intervention, although because part of the goal, of course, is to help people process traumatic memories and integrate difficult life experiences into their lives. It does involve sometimes talking about traumatic experiences. Okay, so why is it so important to treat PTSD in particular in people with severe mental illness or serious mental illness? And I'm saying this as opposed to, say, treating the broader sequelae of trauma in this population. Okay, well, first of all, trauma is very common in people with severe mental illness. And so is, as one might expect, rates of post-traumatic stress disorder. We know that lifetime rates of PTSD in the general population generally hover between, say, 7 and 10 or 12%. In people with severe mental illnesses, it's much higher. A meta-analysis done by, or two of them done by Moritz and Zammit, estimated rates in the 30 to 33% range. Now, it's interesting because a lot of people are very concerned about the high rate of PTSD in people with schizophrenia, and they should be. It's very high. But people are often less aware that the rates of PTSD in people with major depression often on disability, SSI or SSDI, because of the severity of their major depression, with a somewhat later age of onset, receiving services at community mental health centers are even higher. The rates in major depression, and typically undiagnosed in their charts, are usually around 50%. And similarly, now there's an assumption that borderline personality disorder is associated with PTSD always. And that's not quite true, but the rates of PTSD in borderline personality disorder are about 50%. And so that's why this book doesn't just focus on people with schizophrenia spectrum disorders, but includes the broader range of people who are also highly vulnerable to having PTSD, and where PTSD is very infrequently assessed and documented in their charts. So I've mentioned that it's usually not documented. There's a whole series of studies showing rates of PTSD in the 30 to 50% range, and typically about 5% of the individuals with PTSD have it documented in their charts. Another reason for why it's important to treat PTSD in particular, well, first of all, we know a great deal about the disorder, and we have very effective treatments for it in the general population. But we also have good reasons for thinking that PTSD interacts with and worsens the course of serious mental illnesses. So within this figure, the black part of this figure is a model which we developed over 20 years ago, proposing how PTSD interacts with the course of severe mental illness. So you have the symptoms of PTSD, overarousal, re-experiencing, avoidance, that can directly contribute to symptom severity, as in the form of daily stressors and so on. Then you have interpersonal relationship difficulties, because most trauma is interpersonal, interfering with a working alliance or therapeutic relationship, leading to receipt of fewer illness management skills, pharmacological, psychotherapeutic, supportive, and so on, worsening symptoms. Then we also know a common way of coping with PTSD symptoms is substance use. And substance use, of course, can worsen symptoms. It can also increase risk of re-traumatization, which itself can exacerbate symptoms as well as worsen PTSD. So there's many both direct and indirect ways in which PTSD worsens the course of severe mental illness. Now, what this does is this shows how there's also cognitions. The focus of this intervention is on teaching people how to recognize, examine, and change inaccurate trauma-related cognitions that underlie PTSD. This is based on cognitive theory of Ehlers and many others going back 20, 25 years and longer. So here we have, oh, here we go again. Once victim, always a victim. A thought related to re-traumatization. Or here, oh, I've been singled out as a weak victim. A lot of people think that the cognitions associated with PTSD are always those involving fear and danger. But there's a great many cognitions that involve the self, looking at oneself as defective or tainted in some way. And then also look at in terms of interpersonal relationships. And so this model works on helping people identify these cognitions that maintain PTSD symptoms in order to reduce them and change them. And in the end, reduce the symptoms of PTSD and its effect on the course of the illness. Another reason for focusing on PTSD, it's rather simple, so straightforward to assess. You can assess PTSD through a combination of a brief trauma screen and then a self-report, a measure like the PTSD checklist, which you want to verify then with a clinical interview, all in about 15 minutes. And as mentioned before, there are effective time-limited interventions for PTSD in the general population. And it turns out that there are similar interventions, in particular the cognitive restructuring program, that are also effective. The cognitive restructuring program generally takes 12 to 16 weeks, although some people get significantly better in even less time. So what's the difference between trauma-informed treatment and trauma-specific treatment? Many of you have probably heard of trauma-informed treatment. I wouldn't be surprised if many of you, haven't already received training in it, but it is different. So trauma-informed treatment is really aimed at creating a sensitivity and an understanding of the impact of trauma on people's lives, especially disenfranchised individuals, individuals with serious mental illnesses and the like, with a number one goal of avoiding re-traumatization, because unfortunately, so many of the people who have had trauma throughout their childhoods, young adult lives, when they seek help or when they get into a helping situation, have ended up getting re-traumatized by the very people who are supposed to be helping them. So the number one goal of trauma-informed care is to raise this awareness of helpers, to create a helping environment, and whenever possible, to avoid re-traumatizing individuals. And so that's an importantly, a critically important groundwork that needs to be done in terms of trauma-related work. Trauma-specific treatment is treatment that focuses on the specific psychological consequences of trauma. And when it comes to the DSM, when it comes to the classification of psychological consequences, although we know there are many, many sequelae of trauma, the syndrome or the disorder that has the most established track record in terms of research and treatment and the like is post-traumatic stress disorder. And so trauma-specific treatment refers to the ability to treat the specific consequences of trauma, namely post-traumatic stress disorder. And so while there's a great deal of work that's been done in terms of the dissemination of trauma-informed care for people with serious mental illness, much less has been done in terms of the dissemination of the treatment of trauma-specific outcomes like PTSD. And of course, I think this is where the money is, because these are treatable syndromes associated with very, very high levels of distress, increased service utilization, emergency room visits, length of stays, and things like that, and high levels of distress in the lives of individuals that we can greatly reduce through a time-limited intervention, such as a 10 to 15-week intervention. So what is unique about the cognitive restructuring program? First, it's the first empirically validated and replicated standardized intervention for treating PTSD in people with severe mental illness. There are other interventions out there. There are some exposure-based interventions. People have had some success with EMDR, eye movement desensitization and reprocessing, but none of those studies has been replicated at this point. And all of those studies have focused on more narrow populations of people with serious mental illness, usually people with psychotic disorders, whereas all of our research is focused on people with severe mental illnesses, including major mood disorders and including people with borderline personality disorders. In fact, in our two largest trials, about 25% of the sample has had borderline personality disorder, in addition to either major depression, bipolar disorder, schizophrenia, or schizoaffective disorder. So the program focuses on teaching cognitive restructuring, and therefore has similarities to other cognitive restructuring or CBT approaches to PTSD, such as that studied by Marks, and such as cognitive processing therapy developed by Resnick. Now, cognitive processing therapy has an exposure component, but research has been done evaluating whether the exposure component contributes to the cognitive restructuring component, and it's found that it doesn't add to the outcome. So cognitive processing therapy really is another somewhat similar approach. But this approach is unique in that it focuses on teaching people how to recognize and change distressing and inaccurate trauma-related thoughts underlying PTSD. It takes a real skills-based approach. The clinician's not in there actually trying to change people's thinkings and beliefs and so on, but focuses more on teaching a set of very basic skills for first identifying thoughts. And what we teach is that the cue to a thought underlying something that needs to be examined is distress. So it's a very easy signal to pick up. If the person is distressed, you examine that thought. And then we teach people how to different rules for evaluating the accuracy of thoughts. And then based on that, either changing thoughts or alternatively, because we know that there's a lot of avoidance in people with PTSD, developing action plans for dealing with distressing situations in which a person evaluates the evidence supporting the underlying thought or beliefs and concludes that there's evidence supporting it. So in many cases, you don't want to change the underlying thought. You want to help the person develop an action plan for dealing with the situation. And this is very important because we know that people with PTSD are much more likely to be re-victimized. And the reason they get re-victimized, it's two things. One is that they avoid signals or messages indicating potential danger. The second is that you get this inflated hyperarousal, and so people can't distinguish real dangers from the noise. And so the focus of this program is really skill-based. We take a unique two-stage approach to teaching cognitive restructuring skills that I think is unique in the field. We find that clients find learning the skill of cognitive restructuring. The final skill that we help people develop is called the 5 steps of cognitive restructuring, a very systematic way of identifying, evaluating thoughts, examining the evidence, and then either changing the thoughts or coming up with action plans to deal with. That's part of the richness of it. And the skills are useful in everyday life. This is another reason for taking a kind of a cognitive restructuring approach. This is a skill for dealing with negative feelings. Any of us can use it, and I do use it, on my regular day-to-day basis. So it's a skill that goes beyond the treatment of PTSD. And it's been tested in a wide range of different populations. So this is the outline of the book, kind of what's in it. The first one just focuses on the problem of trauma and post-traumatic stress disorder in people with serious mental illness. The second is an overview of the treatment model. And the third is focused on understanding and assessing PTSD. I'm especially proud of this chapter. I think that there's more in this one chapter on how to assess PTSD in people with serious mental illness and how to distinguish between, say, psychotic symptoms and re-experiencing symptoms, over-arousal symptoms, versus other symptoms that you often get in psychosis, mania, and the like. As well as what to do about when there are delusional elaborations on traumatic experiences, in which case it's very appropriate to treat the person for PTSD, versus when the very basis for the traumatic memories appears to be delusional in the first place, in which case you're actually better off not treating it as PTSD. If you treat an outright delusion with PTSD, often the delusion grows, as does the distress associated with it. It also talks about the problem of antidepressant precipitated manic episodes. That happens especially common in people with undiagnosed PTSD, because you have undiagnosed PTSD, you have the most common psychiatric symptom associated with that, major depression. You go to a treatment provider for the treatment of depression because you're avoiding the PTSD symptoms. The treatment provider doesn't assess the PTSD symptoms. They prescribe you an antidepressant medication. The antidepressant medication triggers a manic episode, which we know is very, very common, can't be diagnosed as bipolar disorder, but PTSD isn't assessed. The person's taken off of the antidepressant medication, but the symptoms seem to persist. They have difficulty sleeping. There's irritability and the like. Of course, these symptoms are better accounted for by PTSD, but they're given a diagnosis of bipolar disorder. And I have identified several cases of people who've received 20, 30 years of treatment for bipolar disorder because they really had undiagnosed PTSD and they had never had another manic episode that wasn't precipitated by antidepressants. So this then gets into the logistics. This is into beginning treatment, establishing the relationship and things like that. And the way this program works is you have an orientation to the program. Then you have psychoeducation, interactive education about PTSD, using worksheets and things like that, where people can identify their own personal experiences and the like. And also the teaching of breathing retraining. And breathing retraining, of course, is a technique for decreasing anxiety, but just as importantly, it's a technique for decreasing over-arousal. And we've actually seen a lot of improvement in PTSD symptoms just based on psychoeducation and breathing retraining. And we spend the first 3 sessions on that. And then the 4th session, we begin cognitive restructuring. And we divide it into 2 skills that build on one another. The first skill, we call it common styles of thinking. In the more common terminology, we might call it cognitive distortions. But people with serious mental illness, they really don't like to have their thinking referred to as distortions. So we refer to common styles of inaccurate thinking. And things like jumping to conclusions, emotional reasoning, black and white thinking, forecasting, all of those things. And we find that this is a really, really good way of starting it out. This is after introducing the triad, the cognitive thinking and behavior triad, making that connection. Because within one session, people can begin recognizing inaccurate thinking related to negative feelings and coming up with more accurate thinking based on the recognition that the thinking is a common style of thinking. So we spend 1 to 3 sessions on that. And then we introduce Cognitive Restructuring 2, which is the 5 steps of CR. And it builds on the common styles. And those 5 steps are identify the situation, identify the most upsetting feeling, identify the thought related to the most upsetting feeling. And here we eventually teach people the downward arrow, not just one thought, brainstorm a bunch of different thoughts. What's the most distressing thought associated with that feeling? Then that's the one you examine. Evaluating the evidence for and against the thought. And here's where common styles comes in. If you recognize it as a common style, there's evidence against that thought. And then make a decision. Does it support the thought? If it supports the thought, you come up with an action plan. If it doesn't support the thought, then what you do is you modify the thought, of course. And then the third chapter is on Cognitive Restructuring 3. What we do is we teach cognitive restructuring as a skill, working on everyday negative feelings that anybody can have in order to develop the competence and the self-confidence to be able to use the skill. And then we begin to bring trauma-related thoughts and beliefs into it. Now, often, just the negative feelings naturally lead into the trauma-related stuff. But sometimes you need to do a little detective work. We monitor PTSD symptoms over the course of the illness. And so we can bring some of those data in. We always review it regularly with people. And that can sometimes bring you right to traumatic beliefs. But this is the part where we help people use the skills specifically to work on their PTSD symptoms. Chapter 10 is a big chapter on lots of solutions to common problems, cognitive challenges, learning the method, people holding on to beliefs despite lots of evidence against them, and so on. Strategies for dealing with that. And then there's generalization, skill, and termination. We have 2 chapters at the end on working with people with psychosis and working with people with borderline personality disorder. And by the way, we have 3 vignettes who we follow all the way through the entire book, beginning with the assessment and all the way to the end, and with like vignettes and things like that, dialogue and so on, to exemplify or portray their participation in the program. And then as a conclusion chapter, we actually talk about why we think that having this program is both recovery-oriented and an important part of a recovery-oriented treatment system. Last of all, there's a very rich appendix for this book. All of the educational handouts in the printed book are also available online, can be given out freely to anybody with the book. And then there are clinician tools for goal setting, tracking, and things like that, a whole wealth of tools. Then all of the tools, the handouts and the worksheets and stuff are available in Spanish translation. It's not in the hardcover book, but it's in the online book. And then there is a chapter. We actually have a version of this program, I hate to admit it, but it's 3 sessions long that's been shown to improve PTSD a hell of a lot more than we ever expected. And we call this the Breathe intervention. It's been studied in a whole bunch of different populations and one controlled population. It makes up the difference between 0 treatment and our full cognitive restructuring program by about 50%. So there's actually a lot of people who benefit just from this 3-session intervention. So there's a chapter on the intervention, only in the online appendix, and the entire treatment manual. And the entire treatment manual is basically the first 3 sessions of the program, the psychoeducation and the breathing retraining.